Hey guys, Nick here. Welcome back and welcome to Renal Anatomy. Now this section may seem like it requires a lot of busy work or a lot of memorization, but hopefully by the end you'll see that the renal system is very practically organized, and that this organization allows for the kidneys to perform their ultimate function, which is to basically conserve water while eliminating waste. In order to appreciate this function, we'll have to take a look at the kidneys at both a microscopic and a macroscopic level. So let's get to it. At the gross anatomical level, the kidneys are retroperitoneal organs located at the level of which vertebrae? Correct, T12 to L3. Now the kidney is slightly lower on the right, basically due to the presence of the liver, but if you see a question like that on the exam, T12 to L3 is the answer you're looking for. The kidneys are the K in the very popular Sadd-Pucker mnemonic used to list all the retroperitoneal structures. Let's quickly run through that together. The S stands for the suprarenal glands. The A is for the aorta and IVC, or inferior vena cava. The D is for the duodenum, specifically the second through the fourth parts of the duodenum. The P is for the pancreas, except the tail. The U is for the ureters. The C is for the colon, specifically the ascending and descending colon. The K is for the kidneys. The E is for the lower two-thirds of the esophagus. And the R is for the rectum. Now you'll see all these structures again once you go through the GI videos, but it doesn't hurt to take a few moments to review them real quick right here. The kidneys receive blood from the renal arteries, which branch from the abdominal aorta at the level of L1. They drain venous blood through the renal veins to the inferior vena cava. Keep in mind that the renal veins pass in front of the renal arteries and aorta. There are two major points I want you guys to remember about the renal veins. The first is that the left renal vein is longer than the right, and that's why it's chosen for the living donor transplantations. Now, anatomically speaking, why is the left renal vein longer? Well, the IVC lies to the right of the aorta, so the left renal vein simply has a longer distance to travel from the left kidney. The second important point I want you guys to remember about the renal veins is their relationship to the gonadal veins. Now, as seen here in the image, the right gonadal vein is draining directly into the IVC. The left gonadal vein, however, is draining directly into the left renal vein, draining blood towards the IVC. Now, due to the distance the left renal vein has to travel and the angle at which the left gonadal vein branches off, there's backup pressure that builds up and pushes blood back into the left gonadal vein. Now, as a result, testicular varicocele are more commonly seen on the left than they are on the right. Now, do you remember what a varicocele is? Well, it's an enlargement of the pampiniform plexus found in the spermatic cord of the scrotum. Blood basically backs up from the IVC to the renal vein to the left gonadal vein into the pampiniform plexus. This is a very, very painful condition that can reduce fertility. Now, sperm production generally occurs at a lower temperature than body temperature. That's why the scrotal sac exists outside and not inside of the abdominal cavity. This will be discussed further in the reproductive chapter, but it's always important to keep in mind the pathophysiology behind something you might see on an exam. Now, this is a gross image of the left kidney. As you can see, the left gonadal vein is draining directly into the left renal vein, moving blood back towards the IVC. If you follow the course of the ureter, it will generate here in the hilum of the kidney and move inferiorly towards the bottom of the image. Now, unfortunately, the scope of the image ends just prior to the interaction between the ureter and the gonadal vessels. However, do you know the relationship between these two structures? Well, the ureter will course underneath the gonadal vessels. Now, this is important and is often tested on board exams, so we'll talk about this in further detail in just a few minutes. Another part of renal anatomy involves its sensory innervation. The kidneys send sensory innervation to the spinal cord at about the level of T10 and T11. Thus, pain in the kidneys is often sensed in the T10 and T11 dermatomes. On a physical exam, one can elicit that pain at the costovertebral angles. On the test, costovertebral angle tenderness is often a huge clue that will point you towards the kidneys as the culprit for the patient's symptoms. For example, Pyelonephritis commonly presents with this type of pain distribution, so be sure to give some time to the physical exam findings described in a question stem. It can save you a lot of time overall and point you towards the right answer of that question. Flash quiz. Why is the left kidney, rather than the right one, harvested for transplantation? Well, because the left kidney has a longer renal vein, like we talked about. On cross-section, the kidney is split into the cortex, the medulla, and the collecting system. The medulla consists of the renal pyramids and columns, while the renal cortex consists of the parenchyma above the medulla. It's like an orange, where the fruit inside is the medulla and the orange peel is the cortex. The collecting systems begin as the minor calyces. Each renal pyramid drains into its own minor calyx via a renal papilla, seen here. The minor calyces coalesce to form major calyces, which drain eventually into the renal pelvis, seen here. The renal pelvis then drains into the ureter, which goes into the bladder. Finally, the bladder drains into the urethra, which has two sphincters, an internal and an external sphincter. Now, which sphincter do you think is under voluntary or somatic control? Well, that's the external sphincter. The internal sphincter is under involuntary or autonomic control. The vasculature system of the kidney begins as the renal artery. From the renal artery, segmental arteries will be formed. From the segmental arteries, lobar arteries will branch. And from the lobar arteries, interlobar arteries will be formed. Now, as the interlobar arteries arch over the renal pyramids, they will become arcuate arteries. Now, not seen here in the image, the arcuate arteries actually give off interlobular arteries seen at the tip of the renal pyramid. And at a microscopic level, these interlobular arteries will then give off the afferent arterioles, thus bringing blood to the glomerulus. A quick way I remember the renal vasculature is through a mnemonic: real sports lover interests are intertwining always. To me, I just picture two strangers meeting for the first time, and chances are they'll find some sport as a common interest and they'll forever have something to talk about. Now granted, this isn't exactly extremely high yield, but it's something you want to look over maybe a couple days or a couple hours even before your exam, because these are the kind of easy points that you want to pick up while you can during the test. And with that, we have reached microscopic anatomy. Now in microscopic anatomy, the way I remember afferent versus efferent is that afferent is arriving while efferent is exiting. The afferent arteriole brings blood to a tuft of capillaries known as the glomerulus. This is where filtration of the blood occurs. Now, on an exam, the question stem might describe someone who's presenting with signs of weakness, anemia, and hypotension. The patient may have recently experienced severe hemorrhage or several days of diarrhea, their blood pressure is 95/60, and the question is going to ask you, what's the body's long-term mechanism to restore intravascular volume in order to raise the blood pressure? Well, the kidney is going to secrete renin. Now renin is an enzyme that converts angiotensin to angiotensin 1. Angiotensin 1 will later be converted to angiotensin 2 in the lungs. Any idea what enzyme catalyzes the second reaction? Correct, angiotensin converting enzyme, or ACE. Angiotensin 2 does two things that increase the blood pressure. It causes vasoconstriction and enhances the release of aldosterone, which goes on to cause salt and water reabsorption from the kidney. Now this will all be covered in more detail when we go through renal physiology, but it's important to know that renin is what starts the cascade of reactions that lead to an increase in blood pressure. Do you know where renin is secreted from exactly in the kidney? The juxtaglomerular cells, or the JG cells. These cells are modified smooth muscle cells located in the tunica media of the afferent arteriole. Now quickly, in addition to decreased blood pressure, what are some other factors that stimulate renin secretion? Decreased sodium levels and an increase in sympathetic tone. Now, plasma from the blood is filtered into the beginning of the nephron, which is called Bowman's space. At this point, the plasma is now called filtrate, and the filtrate passes into the proximal convoluted tubule. From the proximal convoluted tubule, the filtrate will pass into the loop of Henle, continue on into the collecting duct, continue on into the distal convoluted tubule, and then pass into the collecting duct. The collecting duct will drain into the minor calyx at the tip of the renal pyramid, which is called what? The renal papilla. We'll talk about each of these sections of the nephron in more detail during renal phys, but it's important to know from an anatomic perspective how filtrate is created, where it's created, and how it passes through the nephron. Now, one last point to keep in mind is that the efferent arteriole continues on to form a network of capillaries around the nephron called peritubular capillaries. Now, what will be the function of these capillaries? Well, they'll reabsorb filtrate, unlike the glomerular capillaries, which do what? Filter the plasma. Flash quiz. What is the first component of the nephron that filtrate will see after leaving Bowman's space? Answer: the proximal convoluted tubule. To finish up this section, we're going to continue our flow down the ureters. The ureters are retroperitoneal and thus pass underneath the uterine artery or vas deferens. Keep in mind water under the bridge, meaning the ureters are carrying water, or in this case urine, under the bridge, which is the uterine artery or vas deferens. This plays an important role during pelvic surgery, so this fact tends to be high yield on exams. During gynecologic procedures involving ligation of the uterine vessels, the ureters may become damaged. Now, what conditions can result from ureteral damage? Well, this can lead to urinary obstruction, hydronephrosis, and post-renal azotemia, something we'll come to talk about when we study renal failure. Another anatomical fact that can be tested is the arterial supply of the ureters. It's worth knowing that the upper third of the ureters is supplied by the renal artery, the middle third is derived from the gonadal and common iliac arteries, and the distal third is supplied mainly by the branches of the internal iliac artery. On the exam, they might describe a patient that is presenting with severe intermittent flank pain that radiates to the inner thigh. The patient may also report dysuria, or pain on urination, and hematuria, or blood in the urine. X-ray or CT imaging might show a radio-opaque area within the ureter. Any idea what the most likely diagnosis is? Awesome! Renal tract stones. And what's the most common type of renal stone? Calcium stones. We'll discuss the physiology and pathology of stone formation a little later on in this chapter, but for now, let's finish up with a board-style question. A 22-year-old man arrives in the emergency department with multiple stab wounds. Bedside exploration reveals the wounds extend through the peritoneum. The patient is taken to the operating room where the surgical exploration reveals splenic and hepatic lacerations. No renal lacerations are found. Which of the following describes the anatomic location of the kidneys? Well, the answer is C, approximately at the vertebral level of T12 to L3. The left kidney is higher and more medial than the right. In a case like this, it might be important just to take a look at the answer choices before you dive into the question stem. Oftentimes, the boards might try and take you on some story or journey and then ask you a question that has little or nothing to do with the question stem. So be sure to take your time, take a quick glance at the answer choices, and then review the question stem and go from there. Hey, that wasn't so bad. Now, it's time to replenish your extracellular fluid compartment because we have renal physiology coming up next.